We all know that tuberculosis is a very common problem. It is one of number one infectious agent causing death all over India. And I am going to speak what are the newer diagnostic tools and ways of managing tuberculosis. Tuberculosis is an infectious disease caused by bacterium, Mycobacterium tuberculosis. This is all we all know. But Mycobacterium MTB complex, that is Mycobacterium tuberculosis complex, these are other Mycobacteria species. They can also cause tuberculosis in human beings as well as in other living things. The examples are Mycobacterium africanum, bovis, Microti, Canetta, capri, and these other organisms. So, whenever we see tubercular bacteria on a smear, it's very difficult to identify whether it is typical this Mycobacterium tuberculosis or it's a Mycobacterium tuberculosis complex. These are other mycobacteria and they are identified only on cultures. MTB was identified on 24th March 1882 by Dr. Robert Cox, and this is the tuberculosis disease burden, and we can see this looks like some Swiss bank account numbers, but India is top on that. It's not black money accounts, but it is number of tuberculosis burden in India. India accounts has 2.8 millions of TB patients, and 30% of the world TB burden is in India. So we are capital of TB. TB kills one person every 2 minutes and 75 people every day. 3 lakh children drop out in the school because of TB. 64,000 estimated cases of MDR TB only in India, and there is lost wages because of tuberculosis and many other problems. So the important issue is we require more intense care and innovations in this for reducing this tuberculosis burden in our part of world. Global incidence is 9.6 million, Indian annual incidence is 2.2 million. So India is largest, and it has highest TB burden all over the world and 1/5 of the global population. So we all know that the MTB infection, how we catch it. So the bacteria is inhaled into our airways, that is engulfed by the macrophages, and then that goes to our lymphatics. That is the known pathophysiology of getting a tuberculosis infection. However, now because we want to stop this pathophysiology, so the research is going on that the body enters, this is the concept, this is not proven, but the studies are going on that this bacteria enters into the macrophages through the alveoli, through the M cells, that is microfold cells, into our airway tissue, and they travel through lymph node through this cell. So these microfold cells, that is M cells in the alveoli, they have some receptors through which this translocation of bacteria into the macrophages is coming. So the research is going on that if we can block this translocation into the macrophages, so that we can avoid the infection into the human body. So disease onset outside the alveolar macrophages is not possible. So that's why we can halt the tuberculosis process. But this is a concept. They are working on this concept, and things are innovating into this line. Right from starting getting prevention of tuberculosis, tubercular bacteria getting into our body. We all know the diagnosis of tuberculosis. Latent infection we diagnose by TSG, that is tuberculin skin testing, and nowadays interferon gamma assay. Active tuberculosis we diagnose based on our history, clinical examination, radiological features like consolidation, cavitation, infiltrates, bacteriological evaluation like sputum smear positive testing, and we have another methods like molecular methods molecular methods for detection of MTB, that is TB PCR, identification of tubercular which MTB species it is, and detection of resistance for rifampicin as well as INH. There are conventional methods, we all know smear, AFB smear, ZN staining, and culture methods. Immunological diagnosis using TST, that is Montauk's test, and interferon gamma assays. And we have other new diagnostic methods also, NNA, BACTEC, and MJIT. But I would like to discuss over in short on this diagnosis of tuberculosis. One part on the right side is latent infection. Now in India, 80 to 90% of the population is exposed to tubercular bacteria. So most of us harbors tuberculin protein with us. So getting a positive Montauk's test or positive skin testing does not mean that that the person is suffering from tuberculosis. So we need to be very careful while evaluating or diagnosing a tuberculosis case based on Montauk's test. Just a case, today's case in OPD, I was looking, there was a patient of mine who was treated for tuberculosis 2 years back for a cervical lymphadenopathy. And the patient was outstation, she had some fever, she went to some other local general practitioner and she told she has fever and she had tuberculosis 2 years back. So he did again her Montauk's test. And obviously the patient already had tuberculosis, the Montauk's test repeat was coming to be positive. So she came again back to me, sir, मुझे वापस से TB हो गया. But if a person is already exposed to a tubercular bacteria or had suffered from tuberculosis, doing a Montauk's test in a old TB patient won't be of any help. It will be false positive. So we have to interpret the reports again, like depending on what is the total clinical scenario or clinical history of the patient. Similarly, interferon gamma assay also detects tuberculin protein. So the interpretation of the reports has to be dependent on the history of the patient and what is the earlier past history of tuberculosis, whether the patient has or not. Active tuberculosis, of course, the patient has on history, they have cough, fever, loss of weight, loss of appetite. On a CT scan or a X-ray, we see cavitation infiltrates. And of course, bacteriological examination gives us the report. Nowadays, the smear positivity may be less. The sputum smear examinations may be negative. So what we have nowadays is a gene expert MTB complex. We are all aware of nowadays we send samples for expert MTB and rifampicin resistance. We check for rifampicin resistance for MDR-TB. It is a comparatively newer PCR based diagnostic method. WHO has recommended this currently used expert MTB method for diagnosis of MDR-TB. It not only detects tuberculosis via the PCR based technique but also detects rifampicin drug resistance. So we at the same in the same testing we know whether patient has tuberculosis or not, and probability of having a multi-drug resistance is also known to us. The results are quite quick. We get the results in 2 hours. Okay, but that is if we are sitting in Amravati and if we don't have a lab here, so we don't have a result in 2 hours. Once it reaches Mumbai, and then only that sample is processed, and then we get the report within a day back to our place. So it is very fast, and it has a very good sensitivity as well as specificity for rifampicin resistance. The procedure is also very simple. The sputum or bronchoalveolar lavage is liquefied and inactivated in a sample reagent, and then that is there is a test cartridge. You can see this gene expert machine on this picture, and there is a cartridge in which the sample is placed, and we get report within 2 hours. The interpretation of the report has to be also very critical because it shows sometimes MTB detected low or high, and whether rifampicin resistance is detected or not detected. So we came to know about whether it is tuberculosis. The only disadvantage of this method is if there is an old cavitary lesion and the patient has sputum, if it can detect even a dead bacilli because it's a PCR based technique. So the patient can be detected as a dead bacilli, can also be detected as a positive. So you can have a result like MTB bacteria detected low or low level detected, and rifampicin resistance may be yes or no or not detected. So depending on the lesion. So there are limitations to the diagnostic method. Various routine methods, what we do is sputum examination. There is a difficulty in sample collections. Many times the patient is not able to bring up the sample. Inadequate quantity may be there. False positive results may be there during recovery, because though the patient is on AKT, and if the patient is having a cavitary lesion, so patient when expectorates, still the report may be positive initially during the recovery phase, and we cannot do a sputum examination every time for monitoring the treatment response. Skin prick test, interferon gamma assay, as I have told it, they are not useful much, and they are not useful in immunocompromised patients such as HIV, and does not separate patients with active TB from those who are no longer sick or vaccinated against TB. even a BCG vaccinated person can have a Montauk's positive test, okay, because BCG is nothing but a tuberculin protein. So once your body is sensitized to a tuberculin protein, your Montauk's test can be positive. We do as a test Montauk's test only in suspected cases of sarcoidosis. If we suspect a sarcoid mediastinal lymphadenopathy, then we do a Montauk's test, and if Monto is negative, then we are more in favor of a sarcoidosis. So whenever I advise till date in my practice of chest medicine, Montauk's test there was only for cases of sarcoidosis. I have never advised a Montauk's for diagnosis of TB. Gene expert assay, as I have told you, it has some reduced accuracy in HIV patients, as well as they are not useful in monitoring the treatment response, because though the patient is, we have killed the bacteria with the anti-TB medicine, but still the report can be positive on repeat specimen, because it detects the dead TB bacteria also. So because of this limitation of diagnostic methods, there is an underdiagnosis of disease leading to the individual morbidity. Sometimes the physician or the general practitioner, they do only just sputum examination, and if it is negative, they don't start AKT. So it leads to the increase in individual morbidity and mortality and continued transmission of MTB. Sometimes tests like Montauk's test can overdiagnose the disease. When the patient is not having tuberculosis, based on Montauk's we start AKT. So it leads to unnecessary treatment of patient with AKT, and gene expert, if not properly utilized, there can be a delayed diagnosis of drug resistance. So what are the unmet needs of diagnosis of TB? Considering the current limitations of active TB diagnosis, effective monitoring of treatment response, WHO has called up for a new sputum, like non-sputum diagnostic methods, which are easy to run. And earlier this serum IgG, IgM against TB were used, but now they are banned by government, and because they were not specific. So newer blood examinations, that is non-sputum examinations, are now warranted for diagnosis of TB. To reduce the burden, detection gap must be addressed, and new tools has to be developed. So what are the emerging molecular methods? First is Khatri test. This is Dr. Khatri, who is an Indian but based in US. He has developed a non-sputum diagnostic test which is very easy to run. TB has some gene sets like GBP5, DUSP3 and KLF2. They are potential clinical applications for diagnosis and monitoring the treatment response. This Khatri test can be done simple on the blood. It's not right now available, it's under research. And this innovation may bring some change in future in diagnosis of tuberculosis. It distinguishes between active tuberculosis from latent tuberculosis. Advantages are it easier and cheaper than existing methods. It removes the need of collecting sputum. It can be performed without electricity by using solar power PCR machine, and it works even in resistant to in drug resistance tuberculosis also. So it has a near future, but the research is going on. There are few articles only published mentioning some Khatri tests, but they are not like widely available. Another is CTB test. As we know that the tuberculin test or Montauk's test has lot of limitations. So new skin test combining purified protein derivative based tuberculin skin test with highly specific intergamma release assay is now being developed, and that test is called as CTB. It measures body's immune response to two TB antigens, that is East6 and CPF10. These are the two tuberculin antigen against which body presents the response. So specific antigen, this specific tuberculin protein is now being developed called as CTB, so that we can detect a high risk latent TB to active TB. And there are various advantages, that is both CTB and IGRA has specificity of 97%, so we have better diagnosis of tuberculosis. Another is LPA test, that is line probe assay, this is right now available with us in India, and line probe assay testing can be done, which detects not only first line but also second line TB drug sensitivity can be done when we are suspecting a drug resistance tuberculosis. It is DNA-based test identify genetic mutations in MDR TB strains. Of course, this test also has some advantages and disadvantages. The advantages are important that we can get results within 48 hours. Within 2 days, we get reports of line probe assay, and we can decide a regimen for the very sick patient as early as possible. We don't have to wait for cultures wait for 6 weeks for TB cultures. Whatever test I have discussed, the only available is like right now is Gene Expert, that is Expert MTB, and which detects rifampicin resistance, and LPA, that is line probe assay testing, which not only detects rifampicin but also INH and other drugs also, including streptomycin, ethambutol and pyrazinamide. But still the gold standard for diagnosis of tuberculosis and detection of drug resistance is backtech, that is MTB backtech culture. That is still a gold standard for 100% confirmation. Now in short about the treatment of tuberculosis, we all know this chart since years together. This has changed nowadays. The government has now said not alternate dots but a daily treatment of tuberculosis. The regimen remains same. For the first time of tuberculosis, the treatment remains twice HRZD followed by a continuation phase. If there is a relapse, we give 8 months regimen with injection streptomycin. And of course, for the MDR patients or a frequent relapser or chronic tuberculosis, we have to design us or standardize the regimen according to the patient's profile or as per the drug sensitivity pattern. We all know that the problem of MDR is increasing day by day because of improper treatment of tuberculosis. First, if we don't treat tuberculosis properly, or if we don't explain the patient about completing the drug, about its compliance and need of completion of treatment, the TB burden is going to increase. It's not going to decrease. And that's why we are facing the menace of MDR TB. We are very lucky that in Nagpur or Amravati we don't have much of MDR, but in Mumbai the MDR prevalence is more like out of 100 TB patients, 7 to 8% and even up to 10% they are MDR tuberculosis. Even those population who migrate from say Nagpur, what we see that the patients or the young children, young students, they are going to Mumbai or Pune for the education or for jobs, they get contracted with MDR tuberculosis and they are in bad shape. So the treatment of MDR TB is not for 6 months or 8 months, it's for 24 months. And the effective drugs are based on the sensitivity. So we cannot start MDR tuberculosis treatment empirically. We need to have the cultures with us and we need to have the drug resistance pattern so as to optimize the treatment. In intensive phase we have to give 6 drugs and we can see there are 5 groups. This is very important because any physician or any doctor, any chest physician should not treat the MDR case half-heartedly. It is not like that कि patient को drug tolerate नहीं होता, he is having gastritis, so we can give 3 drug first, फिर एक add कर दो. Because if we are going to treat patient half-heartedly with half regimen, unknown regimens, our own generation, coming generations will face the problem of XDR and we won't have any other drugs to treat the patients. So the first line oral anti-TB drugs, we all know they are rifampicin, INH, ethambutol, pyrazinamide. Second line is injectable drugs are streptomycin, kanamycin, capromycin, viomycin. Fluoroquinolones, moxifloxacin, levofloxacin. Second line anti-TB drugs are ethionamide, proteonamide, cycloserine, terizadone, para-aminosalicylic acid and other agents with unclear efficacy, and they are also useful while managing MDR TB. They are clofazimine used in leprosy, linezolid, amoxiclav, thiazolide, imipenem, cilastatin, high dose INH and even clarithromycin is very useful when we have mycobacterium complex treatment. Just in brief, I think I have talked of TB earlier, maybe around 2 years back in Amravati itself, and this TB bacteria is very smart bacilli. The history tells us like history of tuberculosis is older than history of mankind. More than 10,000 years back the TB bacteria was there, and even in the mummies they were found, and there are long back histories there for TB. Mankind history is quite later after that. Cox was able to diagnose bacteria just 140 years back. 140 years पहले ही उन्होंने TB डिटेक्ट किया. Okay, and the treatment gap was, the first treatment started was in streptomycin was in 1943. Nearly after 50 years of diagnosing a bacteria, it took 50 years to detect which medicine can work with it. Till that time there was old therapies like वो lung collapse करके, lungs को pneumothorax induce करके, thoracotomy करके, they used to treat tuberculosis. And so it took 50 years to develop first medicine, and the last medicine was developed was, I'll show you. It was followed by streptomycin, was followed by PAS, and then INH, and after this rifampicin came in 1957. So the DOTS therapy or this RNTCP was started in 1972. Okay, here this DOTS therapy was 1991, quite late after that. And after that we had, I'll show this, moxifloxacin was in 1996. So after 2000, since 16 years, there are no new drug been developed for TB. So we can see the TB bacteria is quite old, the disease is quite old, it has the highest burden, and still we are not able to control it because it's very smart bacilli, and the smartness is because we are not treating them properly. So prevention is better than cure for this bacteria. BCG vaccine, the prevention starts with your life. I like this statement to say that if the vaccination of BCG comes at birth, even जब बोलते, if we are as a student we are asked about viva कि BCG vaccination का timing क्या है, so it is at birth. So in some books mention कि जैसे shoulder बाहर आता है उसको BCG vaccinate कर देते हैं, and the mother feed is later. Okay, so breast milk is later given, but BCG vaccination is first. So you can see the seriousness of bacteria, that once you are exposed in this environment, you have to get vaccinated with BCG. Okay, so that's why we need to treat this bacteria very smartly. Disadvantage of BCG vaccination, it prevents only disseminated form of or dangerous form of tuberculosis in childhood, like this miliary form of tuberculosis. It does not prevent against pulmonary tuberculosis. It doesn't, that BCG vaccination does not provide a sufficient or consistent protection against pulmonary form of tuberculosis. The North Indians, they are less protected by BCG as compared to the South Indians, and the data varies and efficacy is variable. So what we need a newer form of vaccine, so that which can also prevent a respiratory form of tuberculosis even in adults, not only in childhood. There are more than 80 years now. The BCG vaccine was developed in 1920, around 1921, and it was initially administered in children in orally, and then intradermal developed. So newer BCG vaccines, subunit vaccines, that is MTB72, that is in phase 1, and in coming years we may have this vaccination after, of course, successful clinical trials. And again ESAT-6. MVA-85A, this is one of the very novel vaccine candidate, and it has shown immunogenic potential in preclinical studies, and it has it is found to be very efficacious in recent trials. There are various different type of vaccines are in development, and these are just some, they are molecular names, very complex. We also require new drugs. Why and what drugs? The problem is of treating TB is 6 months. The patient feels better after 2 months, and then that's why he doesn't start the continuation phase, or he left in between. So we require a shorter treatment. As such, TB treatment is quite cheap. We require a more safer treatment because rifampicin, INH, they can cause hepatotoxicity, and we want an effective TB regimen to boost up TB elimination. We never talk of TB eradication. We just want to eliminate TB first, okay, because it's very difficult to eradicate TB. Since market launch of rifampicin in 1960s, no new TB drug, bactericidal drug has been developed. Okay, until recent past, these two drugs they are on approval, but that is also conditional approval. That is bedaquiline and delamanid. You must have read in the paper about bedaquiline in Mumbai. In Hinduja hospital, they have tried in XDR cases, that is extremely drug resistant tuberculosis. Both drugs are conditionally approved, and they need to be because of adverse event have been noted. So only in XDR cases these drugs are used. Bedaquiline, it targets the proton pump ATP synthesis, approved for MDR 400 mg daily twice for 2 weeks, and followed by 200 milligram 3 times a week for 22 weeks. Delamanid, it inhibits the mycolic acid on the bacterial cell wall, approved for MDR 100 mg twice daily for 6 months. There are various new molecules in pipeline against anti-TB. In short, about update of MDR TB regrouping of drug. First group is a fluoroquinolone, levofloxacin, moxifloxacin and gatifloxacin. Second line injectable is amikacin, capreomycin, kanamycin. Third and second line agents are ethionamide, prothionamide, cyclosidine, tethizodine, linezolid and clofazimine. And fourth is an add-on drug which is a non-part of a core MDR TB regimen, and they are also divided into D1, D2 and D3. D1 is what is usually used for the first time MDR TB, pyrazinamide, ethambutol and high dose INH. Whenever we design a regimen for MDR TB, we used first ABC and D1. So we select the one fluoroquinolone. The best one is moxifloxacin. Then we select a second line injectable drug, that is kanamycin. First one is kanamycin, and if not easily available, then we can use amikacin. Capreomycin can also be used, but that is not easily available. Second core line drug, then we used two of this. One is ethionamide and second one is cyclosidine. If patient has some other psychotic problems, then cyclosidine is not used, and then we try to use linezolid. And of this D1, we use pyrazinamide and ethambutol, either of it or maybe both. So we try to get 6 months therapy with 6 drugs. One is injectable and 5 oral anti-TB drugs of second line therapy. So the revised guidelines are in pipeline, and the revised guidelines, they are planning to make duration of therapy from 24 months to 12 months. So they are trying to reduce from 2 years to 1 year. But they are not yet, these are not recommended right now, they are under studies. So shorter MDR treatment regimen is recommended under specific conditions depending on the case, and recommended for all patients with rifampicin resistance tuberculosis, regardless if INH resistance is not confirmed. So once we confirm the rifampicin resistance or MDR TB, we initiate the intensive phase with at least 5 or 6 TB medicine. Pyrazinamide and 4 core second line TB drugs are there. That is, one is moxifloxacin, one other is injectable, that is kanamycin, and 2 other drugs, that is ethionamide or cyclosidine. So to reduce the highest TB burden in country, account for 1/5 of the global incidence, we have to treat TB as well as MDR TB with total complete precision. Continuous research is going on in TB across the globe to support end TB strategy, better understanding of disease pathophysiology, development of newer diagnostic tests, vaccines and drugs at various developmental stages. Since the market launch of rifampicin in earlier 1960s, no new TB antidrug is specifically developed until this recent 2 drugs, that is bedaquiline and delamanid. Rifampicin is the most important integral part of TB treatment, so you have to use it in intensive phase as well as in continuation phase. So we all face the problem of usually hepatotoxicity or liver dysfunctions because of INH, rifampicin and pyrazinamide. So we have this rizorin combination with us, wherein the usual dose of rifampicin is reduced from 450 to 200, and it has a piperine molecule along with it, which is a bioenhancer, and it reduces the hepatotoxicity. So even this combination can be used in patients who does not tolerate AKT well, or they have hepatotoxicity, or they are alcoholic patients who suffers from tuberculosis, because they have liver dysfunction, so they are more prone for having hepatotoxicities. So ultimate aim is to stop TB. We have to reach every patient, treat every patient and cure every patient. Then only we will be able to eliminate tuberculosis. Otherwise we have monoresistant tuberculosis, we may face MDR tuberculosis, and we already have XDR tuberculosis with us. So the scenario of tuberculosis needs to be controlled and addressed very intelligently by the treating physicians. And for complicated cases of tuberculosis, they should be referred to the higher centers. Maybe if not they are not willing for the private doctors, then they can go for a DOTS Plus center in government setups. Even the government of India provides second line treatment of MDR TB free of cost to every patient. And this line probe assay testing is also done free of cost in government centers where DOTS Plus is available. I don't know if sir can enlighten us if it is available in PDMC, DOTS Plus. Yes, sir. Yeah. So thanks a lot for a patient hearing. If you have any questions, you can ask.
What is your clinical experience, and would you like to enlighten on it?
Yes. Hemostasis, to achieve the hemostasis. If patient massive hemoptysis more than 500 ml, the patient can be subjected to bronchial artery embolization, because the bronchial artery, if they are bleeding, the pulmonary this airways, they have a volume of just 150 ml. If patient is bringing out more than 500 ml of blood, he has a chances of asphyxiation. If he aspirates his own blood, he will die of hypoxia. So in that case, an emergency BAE can be done if patient has continuous hemoptysis. That is bronchial artery embolization. That stops hemoptysis just for 48 to 72 hours. By the time we can stabilize the patient, we can start antibiotics, we can start AKT, we can give him vitamin K, Silate, and control the hemoptysis. If still not, then the patient has to be subjected for lobectomy or pneumonectomy depending on the lesion. Bronchoscopically also we can stop hemoptysis with the help of bronchoscope. We inject glue inside the subsegment from which the bleeding is coming, and that glue causes some temporary, it is like just putting a gauze piece on that bleeding segment, and it can stop hemoptysis for a short while. The old case of tuberculosis coming with recurrent hemoptysis, then we need to be very wise. We need to see whether it is just some secondary infection in the older TB scar, or it's an active tuberculosis. So we may require again a repeat bronchoscopy for that patient to see whether there is a TB bacteria sitting inside the pulmonary lung parenchyma. So if a patient again has a second episode of hemoptysis after TB treatment, then we need to be very wise to restart the TB treatment first. It can be just a simple case of secondary infection. Doctors, they are specifically used in some dedicated research center. Hinduja has it, and I don't have the experience of using bedaquiline. Side effect.
What test? Says it is just full form. Its full form is cartridge-based nucleic acid amplification test. Nucleic acid amplification
of CBNAT or expert gene has to be done as per patient history. That is very important, because we see many times, say like if patient is first time of tuberculosis, he has just right upper lobe consolidation, then no. But if the patient has a death of any family member because of tuberculosis, then we suspect an MDR TB. In such cases, you can advise even at the first attempt. So we have to take the history properly and how long he is suffering from. No, that's what I'm saying. You can over-diagnose some cases in that case.
Sir,
There is a problem of over-diagnosis.
gene expert test.
Already,
Because government is providing free of cost, it is free test, but otherwise it's a costly test.
it's a costly test.
One question,
Yes.
you said
Secondly, I would also like to like to inform you. We see many patients like serum TB PCR. We see blood TB PCR being done. This is of no use. It's wastage of money for the patient. So at least don't do blood TB PCR for patients. Like we cannot get anything out of it.
one question, you said among quinolones, so would you
That
highlight
is-
please what dose of moxifloxacin one should use?
Moxifloxacin 400 mg twice a day, depending on the weight of the patient also. But 400 to 800 milligram can be given.
But what we heard till now is levofloxacin, moxifloxacin carries almost similar.
It is similar, but like given the research paper weightage on books, it appears moxifloxacin has more MIC than levofloxacin.
So take home message is to try.
The levoflox and moxiflox or gatiflox only for TB patient.
MDR.
We don't treat this any upper respiratory tract infection with this molecule.
Yeah,
We use cefuroxime, we use cefixime for that, but we don't use leoflox or moxiflox for even for asthma patients, even for COPD patients.
That's
So
what-
we try to reserve that drug for only TB patients.
Yeah, definitely.
Yeah.
That we are following.
Yeah.
But out of these two drugs, one should select moxifloxacin. This is a take home message for me.
Means like my personal experience is moxifloxacin. My teacher's teaching was moxifloxacin, and what I read was moxifloxacin, and it is well tolerated as compared to levofloxacin also. No, in a critical care setting you can always use. In a critical, yeah, so we don't have that policy for, yeah, you know, even the BMS can write it. Even a BMS can write AKT. So we don't have that control with us.
Sir, what is the provision in DOTS for the patients on DOTS having drug induced hepatitis? We
They
have
are
to
given the non-hepatotoxic drug. The patients, they are
Is it available in DOTS to change over the treatment to non-hepatitis
Yes, yes,
drug?
yes. They cannot give a patient who is having liver dysfunction the same regimen.
They start DOTS and then patient got hepatitis after
Yes,
2-3
yes.
weeks.
They give you ethambutol, they give you levofloxacin and streptomycin. The DOTS has streptomycin. They don't have amikacin with them, so they give streptomycin. Yes. To purchase it separately. Is available even in private setup. That under UATBC program, and you have private pharmacy also dispensing free drug to the medicines, to the patients. This like Forcox, what we use in our private practice, that is also available free of cost. Even Rizorin also, I don't know about Rizorin whether it is available or not yet. So under the UATBC program, AKT is available under daily regimen. I don't know why government is delaying the daily regimen program for AKT, and already they have failed on DOTS. That is appearing as per till date data with us. There are lot many things like transportation can cause damage. The first smear positive may be a false positive, because sometimes nocardia can cause looks that nocardia can be seen like MTB, so that may be reported as smear positive. The gene expert also has its limitation, so that can, if there is a more, what we say, while taking a bronchial with lavage, if we put more lignocaine, which is more acidic, so there may be a false negative report in gene expert. Mycin can be used, that I have mentioned already, but it's not commonly used as into the second line therapy, clarithromycin. That is usually for atypical infections. If some patients has a very odd site tuberculosis, sometimes we see skin abscesses, sternum के पास या bony abscess आ जाता है, localized, patient को कोई symptoms नहीं होता, fever नहीं है, कुछ नहीं, then such patients we send a sample for cultures, and then they have mycobacterium complex. In that case we use ethambutol, rifampicin and clarithromycin for a longer period, for 6 months to 12 months as well.